Good afternoon. I understand right about now the lunch is kicking in and all the blood is rushing from your brain to your stomachs, and I hope I'll be able to keep you awake just for a little while longer. Um, as Dr. Hayes says, I am from the Centers for Disease Control and Prevention, the Division of Reproductive Health. And the whole mission of our division is to support positive, equitable outcomes for all women. And part of our task is doing that. It includes public health surveillance, research, leadership, and also supporting efforts in states and sort of participating in the partnerships and bridging some of the divide between states and the federal government, and also among different organizations within the country. And I feel privileged to be able to take part in this talk, not only as an obstetrician, but as a public health professional, as a mom. And so I've been given the daunting task of reflecting on the workshop and talking about future research needs. So before I begin, I just like to focus on this quote. I was thinking and reflecting on this workshop, what should I talk about? How do you actually reflect? And this quotation came up, and that learning without reflection is a waste, and reflection without learning is dangerous. We've just spent 2 whole days talking about this issue, and it would be a complete waste of time if we moved forward without actually reflecting on what we've learned and taking lessons away and actually applying it to the future. It was brought up earlier in the workshop that we're here again 30 years later, but really not much has changed. And a lot of the plans and agenda for research that were implemented 30 years ago still haven't been completed. But the positive thing about this all is that although everything hasn't been completed, we have made some progress, and we do have this opportunity right now to chart out a new agenda for research in this area. So first, I'll just talk about what have we learned. So from the very beginning, we realized that the landscape of births in this country has changed significantly over the past 30 years, and our colleagues at NCHS very well pointed out that there have been substantial increases in births to women who are older. There are more births among women of Hispanic ethnicity, and that a lot more women are gaining more weight during pregnancy. So the risk profile of women giving birth are very different. We also have learned that cesarean births in this country have, although they've rose significantly, nearly 60% from 1996 to 2009, there's been a steadying of that rise in cesarean births, partly due to the efforts of a lot of people in this room. And there's even been a small decline. Other successes that the preterm birth rate has fallen for the 5th straight year to 11.72%. And there have also been substantial decreases in the low birth weight rate and the number and rate of triplet and higher order multiple births. So we've also learned that there have been differences in the various settings where birth is happening. The percentage of births outside the hospital has increased rapidly from 2004 to 2010. And although there has been that recent rapid increase, we also have to come to the realization that that actual number is really still pretty small, only 1.2% of births in 2010. We also want to point out that more out-of-hospital births do occur among older, multiparous women with lower risk profiles, and that 2/3 of out-of-hospital births were at home, where about 1/3 were at birthing centers, and that the majority of these out-of-hospital births are planned. So now that we have this new knowledge, what are some areas that haven't quite been well addressed and that we still have gaps? Although we do know more about where women are having birth, we really don't have a good capture on a national level of the planning status of home birth, and that there are still many states who aren't reporting this or aren't utilizing the most recent birth certificate, and that states are in varying stages of implementing the revised birth certificate. The good news, however, is that by 2014, all states should be implementing the newest birth certificate. Other gaps include reporting of transfers from alternative birth settings. We've gone through this over and over throughout this workshop, that home birth patients who are transferred may not be determined from the birth certificate, and that reporting is not necessarily required in all states. There is one state that was brought up during the workshop that has added transfer of births um, from home to hospital settings on the birth certificate, and we can gain additional knowledge from that state. And hopefully more states will be able to take this on, since it has been discussed that there are limitations to revising the birth certificate again. The other gap that has been brought up is that in terms of reporting of the birth attendant, the birth certificate and vital records have been limited in terms of really knowing who all of the providers or attendants are in the other categories. And part of that is because there's variations throughout states in terms of who's licensed, who is able to attend births. And part of it also is that we're not capturing it. So moving on to the next issue of assessment of risk, we did learn that this issue is very complex, and on throughout the workshop it was discussed that we really don't have a clear definition of what is low risk, and that different studies have looked at it in different ways. We did realize and acknowledge, though, that risk is dynamic and subject to change, and that the risk of mom must be balanced with the risk of the baby. More importantly, we also need to realize that risk perception varies between providers and patients, and that the same value is not placed on risk by providers as the value that's placed on it by patients. And cultural views, women's views, and structural conditions can contribute to risk and risk perception. The other important point, though, and that I think was brought up, and I would like to highlight again, that the overall risk, absolute risk of adverse events in all birth settings actually is pretty low. In terms of knowledge gaps in risk assessment, we need to determine uniform definitions of outcomes, and there are several efforts underway that have been discussed, including the Revitalize effort to develop these uniform definitions. The other thing is risk assessment tools for maternal morbidity and mortality. Although a lot of attention has been paid to neonatal risk and neonatal levels of care, there isn't a similar type of risk stratification for maternal morbidity and mortality, including a consistent low-risk criteria and descriptors of maternal resources and levels of care. In addition, there continue to be gaps in predictors of neonatal maternal complications and predictive triggers for elevation of care or transport, and also the role of providers in the care system and what role they play in contributing to that risk. And one thing that seemed to come up, and it was very evident the first day when I walked into the room, in terms of interprofessional working relationships, I realized just first off that there you could tell who were the midwives and who were the physicians. Not just on appearance, but just in the conversation and walking through the room and realizing that a lot of the discussion and the dialogue during the workshop was pretty separate, and that there is a definite need for improvements in the interprofessional working relationships. And with that, in terms of consultation and transfer of care, there needs to be more work done on how to improve that. And then the other issue in terms of risk were thresholds for intervening in high-level care facilities. It was brought up multiple times that a lot of reasons why women are choosing home births is because of the risks that are perceived due to hospitals because of the level of intervention, and that there needs to be more work done, not so much on the intervention and how fast you can get to a delivery or in terms of safety, but other outcomes in terms of harm to the patient, and also how they perceive their care and their satisfaction with their care. In terms of health outcomes, there was quite a bit of debate, and what we can say, there are many things we have learned, but much to learn still. But in terms of the main studies that were discussed during this workshop, alternative birth settings have been associated with less intervention, fewer complications, high transfer rates in some instances, and no differences in perinatal death rates. However, home freestanding alongside midwifery units in a study in the United Kingdom has been shown to be associated with decreased interventions, increased normal births, high transfer rates, and increased neonatal risk for first pregnancies with home births. And then that controversial study that looked at increased neonatal mortality. We have also learned more about the process of care and that it does play a role in the impact on health outcomes, and that the built environment has an impact on neural immune connections and on health. And outside of the birthing environment, that applies in every setting. When I came into this room, just the size of the room, the way people look, just how comfortable you feel in an environment affects your stress level, and how we need to study more about how environment affects patients and patient outcomes. So as I said before, there are definitely some gaps that need to be addressed with health outcomes, including an evaluation of all birth settings, comparing women of equal risk in all of these settings. It was highlighted that there really are no randomized controlled trials of freestanding birth centers. The one meta-analysis of home birthing that showed one trial, and that there are lots of observational studies, but not really any randomized controlled trials, which is considered the gold standard. However, it was acknowledged, and we do acknowledge the difficulty in randomizing patients in certain birth settings, and that all birth settings within a category are not created equal. Everyone's home is not the same. All birthing centers are not the same. There's a lot of variety from state to state, but this is definitely a gap in an area that of research that needs more attention. Other gaps include studies with consistent process and outcome measures. When trying to pull together meta-analyses and comparisons of studies is very difficult because the outcome measures are very different. Some of the examples that were given include assessment of pain relief, effective pain management on the baby, effects of successful breastfeeding, and physiologic and biochemical measures. A point that was also brought up again in the previous talk is that we need more studies with longer term outcomes, not just in the immediate neonatal period. And also, since it has implications for future health, including studies on developmental origins of health and disease. And then lastly, but surely not least, there's still a gap in terms of the optimal process of care. So workforce issues. We've learned quite a bit about this, but I realized that the workforce issue discussion is pretty much just limited to who was here in the room. We talked about nurses, we talked about midwives, we talked a little bit about docs. There are other members of the team that not necessarily were represented and talked about today. We realized that the supply trends for different staffing models are variable by profession, and that we've also learned that the number of births the attendance of births have shifted in this country, and that there are increasing numbers of midwife attended births in and out of hospital. There's also state variability of who is licensed to do what. And we also learned that certain staffing models have been shown to improve patient outcomes, including competent nursing staff and collaborative teams of care. However, there are gaps in terms of what role does education and certification play in the quality of care that's provided. We really don't have a handle on ideal staffing models and what it should look like. What should the team look like who's taking care of a patient to optimize care quality? And we realized in looking at how things are done in the United Kingdom, they're very different than how they're done here. For example, they have midwife attended births, they have doc attended births, but they don't necessarily have labor and delivery nurses as a part of that care model. And then we really don't understand or know what the impact of the missed nursing care is in and out of hospital settings here in this country. We also have gaps in how nurse staffing affects quality and safety and cost of hospital-based care, and also the impact of technology on workforce training needs and demand. In terms of data systems and measurement, we learned quite a bit. Since the last IOM meeting on this topic, we have come a little bit further in terms of data sources to inform outcomes for birth settings. The U.S. standard certificate of live birth has been revised since then, and we are able to gain additional information regarding birth settings. There are also ability to link birth certificate data sets to other data sets, including discharge data and Medicaid data. There are registries, data from payers, and also state-based collaboratives, which were mentioned briefly, but State-based collaboratives are a great opportunity for states to focus on what the problems are in that state and actually use the resources and the data that's available for that state to address the issues within that state. Professional organizations have also played a role in terms of providing data. We also learned about the CMMI Strong Start Initiative, which is another opportunity to gain more information on the measurement of outcomes, in particular for preterm birth and the cost of care, along with other outcomes of interest. Trying to move along here. I know time. How much time? I'm okay? Oh, I'm almost done. So in terms of knowledge gaps, we talked about the limitations of the data systems that we have available. I won't go through each of them again here, but there are definite limitations to what we have, but we do have more than what we did have. In terms of cost, value, and reimbursement issues, a lot of emphasis was placed on Medicaid, and rightly so, considering that they're the payer for 40% of US births. It is good that we've learned that there are certain incentives to try to reward providers for lower cost, high quality care. However, that really doesn't help in these situations and instances where care is not being covered by Medicaid, and the issue of Medicaid not covering certain out-of-hospital births and the variability from state to state was also brought up, and it's an issue that will need to be addressed in the future. There have been some data presented also about the cost of care, but we do need more data from state to state that we can look at on a national level. Not a lot of data from managed care organizations. As I said, there's definite need for more cost comparison data and cost effectiveness data and national level cost data. So as I come down to the end, where do we go from here? We know what we've learned. We know where the gaps are. And of course, I didn't mention all of what we learned and all of the gaps. There's not enough time or space to discuss everything. However, there are some key things or key topics that were brought up during the workshop as a starting point in terms of a research agenda that we can talk about. As I said, this list is not exhaustive, but it is a start. It was definitely brought up that there is a huge gap in terms of having randomized controlled trials and evaluating freestanding birthing centers and other birth settings. And also the impact of interventions in the hospital setting in terms of harm to the patient or hindrance of or poor outcomes for patients. And I'd just like to highlight that when looking at these randomized controlled trials, it's important that we not just focus on one setting, that all of the settings need to be evaluated rigorously. In terms of other studies that need to be done, a lot of these topics were brought up during the workshop, and it's important that we have evaluations of organizational models of care in all settings, and some sort of study, a way to look at most effective methods of transitioning care from out-of-hospital settings to the hospital. That seemed to be a huge topic and an area of great importance in terms of improving quality care and safety for patients. Also looking at the impact of transfer on women and care providers, the determination of predictors of risk and for complications, the evaluation of potential unintended impact of intrapartum care processes, and other studies that will be also important to include in this agenda is cost assessment, cost effectiveness, access to care, which really wasn't discussed much during this workshop, but that's also a very important issue in terms of access to care. We're talking about safety and quality, but what is available to women in various communities throughout this country, and being able to understand that better. Evaluation of continuity of caregivers, and evaluation of the experience of maternity care in different settings. And lastly, but surely not least, it's important also to understand the effect of the environment on neuroendocrine immune interactions and physiologic responses. So, in addition to research needs, the whole purpose of the research is to inform policy and inform practice. There were other needs that came up during the workshop that I think are very important to consider in forming our research agenda, because the research agenda will inform policy. And it's important, and the thing that came up, and I don't want to get on a soapbox, but our vital record system is very important, and a lot of providers really don't understand the importance of the data that is collected on the birth certificate, death certificates, and why that data is used and what it's used for. And I think we in this workshop understand that it is very important, and that we can, as providers, can work to improve the quality of that data. One of the points that were brought up in terms of that was lacking was measurement of transfer to hospital care, and how that's an important part. And although that may not be something that can be immediately added to the birth certificate, it may be something that we could lobby for and talk about in terms of future revisions of the birth certificate. Other important issues: measurement and reporting of perinatal morbidity and mortality for all birth settings. Very close to home for us at CDC. There really isn't a system in place in terms of surveillance or even consistent review from state to state of bad outcomes, and that's in all settings, not just in out-of-hospital settings, but also in the hospital. And also the importance of development of clear protocols for consultation and transfer of care, and the development of risk assessment tools for maternal morbidity and mortality. Other needs that we have is development of consistent policies for education, certification, and licensing of care providers. It's also important to address the cost and reimbursement issues for care provided out of hospital, and that sort of directly follows the issue of licensing and certification. And more importantly, I think the most important thing that I got from this workshop is that there is a definite need to increase the efforts for interprofessional education, communication, and interaction, and that we really need to involve patients in every step of this process. Any time left? Am I done? Okay. Just want to thank you for this opportunity.